is starting to be live streamed on YouTube. Just want to confirm that. We'll give it a couple of more minutes before we get started for tonight.
Folks are still coming in.
Okay, yeah, it is online on YouTube now. Yes, people are still joining in. We had over 90 people register for tonight.
That is really fabulous.
Yeah.
I appreciate. Yes.
Well, and sometimes if somebody can't make it, they'll watch it on YouTube later.
Yeah.
Which is really
A lot
good.
of them watch on YouTube.
Yeah.
Okay, just maybe a minute and then we'll get started. We already have questions coming in. I just want to make sure everyone can chat with everyone. Chat. Okay, looks like everyone can chat. All right, I think we can get started, right?
Mhm.
Okay, good evening, everyone, and thank you for joining us tonight. My name is Ravina Nibalkar, and I'm the Executive Director at NAMI Santa Clara County. Before we begin with our general meeting presentation tonight, I just want to go over the NAMI Santa Clara County updates that might be helpful to you guys. So the NAMI helpline is up and running from 10 a.m. to 6 p.m., Monday to Friday, via phone as well as email, as well as walk-in. Walk-in hours are between 10 a.m. to 2 p.m. After-hour family support is available on evenings and weekends. All our support groups are listed on our website and offered on Zoom as well as in person, so you can look at the schedule. Our website is NAMI-SantaClara.org. For education classes such as family to family, familiar to familiar, peer to peer, persona to persona, provider education, you can contact a helpline number, which is 408-453-0400 and select option 1 for further details, and you can get on the interest list. And so that you can get into the program whenever it's scheduled next. NAMI Basics is on demand, and you can watch it. You can take it on the website at your own pace. And so is NAMI Homefront. The FaithNet Mental Health 101, the next Mental Health 101 is going to be on August 15, and it's at 11:30 a.m. You can call our helpline number if you need more details, or even go to our website. The community peer program continues to match via hospitals as well as self-referrals, all of Santa Clara County. And again, if you're interested in the community peer program, please feel free to go to our website or call our helpline. We are organizing an open house for all those who have taken peer-to-peer class. We'll be sending out an email very soon. The open house is going to be at our office on June 20th, and there's going to be some food available, and you can learn more about the community peer program if you're interested in either becoming a participant or becoming a connector. So keep an eye out for an email from us. We'll be sending out that email only if you've taken peer-to-peer program in the past. The NAMI Walk Silicon Valley is on Saturday, October 5th. Please save the date. We have already launched the website, and you can start your team and let your friends know, let your family know, and hopefully we'll see you there. We just had our NAMI picnic this past Saturday, June 8th, and it was a really good event. I think there were over 120 people who had come to the picnic. This is the first time since the pandemic we had so many people get together. It was really nice seeing all your lovely faces, and I hope you all enjoyed the food, whoever came. Okay, so I am done. I'm going to pass it on to Maureen Milo, who's the Vice President on the board of NAMI Santa Clara County, who's going to introduce a lovely presenter tonight, Dr. Taylor. Over to you, Maureen.
Great. Thank you, Ravina, and welcome everybody this evening. I know this is a very popular program, Ask the Doctor. We are really lucky to have Dr. Catherine Taylor with us tonight. She's going to talk a little bit, before you have your questions answered, she's going to talk a little bit about some of the trends and what she's seeing at El Camino Hospital, and just give you some insight into what's going on out there. And a little bit about Dr. Taylor as well. She's the interim medical director for mental health and addiction services at El Camino Hospital, and she has been with El Camino since 2007. She's been in many leadership roles, including department chief and vice chief, chair of the Physician Health and Wellbeing Committee, and chair of the ECT committee. Dr. Taylor received her MD from Stanford Medical School and completed her adult residency in psychiatry at Stanford in 2006 with an advanced focus on inpatient psychiatry. Okay, Dr. Taylor, I'm turning it over to you.
Thank you. Thank you for having me. I'm really excited to be here. I've been at El Camino for 17 years. And so I have been mostly an inpatient physician. I'm just sorry, I'm having a little technical issue with my slides, starting out with my notes. So I apologize. Let me, I think I need to share my slides.
Dr. Taylor, before you start, one thing I forgot to mention to everybody is, as Dr. Taylor is presenting her slides and information, don't hesitate to add your questions into the Q&A section of the Zoom channel. You should see a little Q&A box, and just click that on and you can add your questions in there. And if for some reason it should land in the chat box by mistake, we'll grab them and pass them on to Dr. Taylor. Okay, I'm done.
Okay, no problem. I think I'm, okay, here we are. I think it's lost my notes. So we're just going to have to go, let's see, with my notes. All right. Okay. It's into, all right. Let's see. I apologize. Let me just see what happens with my notes here in the current slide. All right. Do we share screen?
Mm-hmm.
There we are. Okay. Let's see. Sorry. I apologize.
That's okay. Take your time.
Okay.
Take your time. That's fine.
Let me just, it seems to have gone out of the presenter mode. So let's see.
We should be able to
sometimes when you've tried, because you tried it in the practice session, it opens up like an extra window on Zoom. So maybe you can just see if it's still open and then you can share that.
Okay, let me just see. Here we go. I think we'll do this. Okay, there we go. Oh, can you see? Sorry, maybe just one more. Okay. Okay, we're just gonna go. Share screen. All right.
Yeah, we can see the screen.
There we go. Okay, we're just going to go without the notes, so I apologize. But nice to see you. Sorry, thank you for the little technological issues. Okay, so here we are. Now, where is it not going again?
There.
There we go. Okay.
So,
there we go. Great. So feel free to reach out if you have any questions afterwards. This is just, I thought I'd include some pictures of our beautiful building at El Camino. We have a beautiful inpatient building, and here it is from the inside. It was built in 2020. But so yes, so thank you. My hope tonight was to kind of talk about what I've been seeing on inpatient psychiatry. What I've seen certainly in the last 17 years is the usual amount of, we've had a lot of illnesses that we have psychotic illnesses, mood disorders, depression, suicidality, and a lot of co-occurring substance use disorders. And I think that's one thing that I was kind of hoping to touch on tonight, is that I've seen such a significant increase in dual diagnosis substance additions to psychotic symptoms or mood symptoms, that with the increase in substance use that we've seen in the last couple decades, we've seen a lot of disorders that have gotten worse as well. Certainly everyone's aware of the drug overdoses and opiate epidemic. In this area, there was a huge increase in methamphetamines, certainly in the 2010s. And there was an increase in methamphetamine and other stimulant admissions in that period of time. It seems to nationally have leveled off a little bit, and that since some of the stimulants, I can get into that a little bit later, but some of the stimulants, it seems have trended a little bit downwards in terms of some of the admissions, that they've been managed at an outpatient level of care. But I think what I would want to notice in terms of what I've seen on the inpatient unit is the change since COVID. Our building opened in 2020. We had a unit that was beautiful in the old El Camino Hospital before they built the new building. And the 21 to 24 beds there, we were seeing a lot of depression, psychosis, schizophrenia. But I think what I saw in COVID when we opened up the new building was a lot more depression and anxiety. There were a lot of people who learned more about mental illness, who had issues just being at home, loss of jobs, all the issues that came with COVID. I thought there was a while there where we saw a lot more depression and anxiety. And then subsequently, the substance use increase, alcohol, a lot more cannabis. We've seen to have more and more people on the inpatient unit with cannabis induced or related illnesses. In fact, I think recently cannabis in terms of the US has actually bypassed alcohol as one of the substances that we see most. I think in inpatient psychiatry, there's also been a significant increase in, fortunately, awareness of LGBTQ issues, a lot of better treatments available, and more, I think what I've seen is more awareness, more people talking about mental illness, more people experiencing it, unfortunately, for themselves, more desire to get outpatient services, but a difficulty. We've had, I think, in general, the system for psychiatric care has been broken. I think the issues with insurance and coverage, inadequate beds, inadequate resources in the community has really made it difficult to get the help that people need. And I think one of the things that I've loved at El Camino is the availability of the services to help people. So recently, in terms of care, we find with COVID, it's been difficult to have to address to get the care afterwards. So there were a lot of places where shelters were closed, or other places we had to find transitions for people. When people had COVID, for example, on our inpatient unit, we often had to house them on the medical unit and wait till they could come into the unit. Now, I think post-COVID, I'm calling it post-COVID, I think there's been a really good sense of community, at least on inpatient. We've been very busy, still having a lot of psychiatric illnesses, a lot of severe mental illness. I thought maybe I'd actually, let me transition into kind of more of the discussion of the substance use. One of the things is that a lot of times people with mental illness also have substance use, or people with substance use can have mental illnesses. They don't have to go together. But actually, about a quarter of people with psychiatric illnesses do have at least a dual diagnosis, and almost 40% of people with substance use disorders have psychiatric illnesses. But least 20% of people in the US have either a psychiatric illness or a substance use. The main ones that previously we were seeing, like alcohol, we see a lot on the medical floor. The cannabis, we see a lot in the psychiatric unit. Methamphetamines, I think the trend, there's been a lot of psychosis that we've seen, but a lot of times people are now trending towards more outpatient care. And I thought later I'd touch on the magic mushrooms because I think there's some interesting news about that. Let me just go into a little bit more about cannabis. Was originally found in the 1960s in terms of being able to identify the compounds that were psychoactive. And there were a lot of studies that starting in the 70s and moving on and noticing what the characteristics were. So recently, I think there's been a lot more research into the synthetic cannabinoids. And that's, I think, the thing that for me has been really different that I tell people is that our pot is now, marijuana now is not the pot of 20 years ago. The potency has been found to be so much higher in whether it's cannabis or THC products that have been taken by the FDA, or whether just even on the street, even in samples that you can buy, the potency is just so much higher. And I think that's what we're seeing is a lot more people using marijuana at a younger age. It's easier to get. And what we're seeing, there's always been an association, or they've found an association with earlier onset psychosis, that sometimes when people are using cannabis in the teenage years, the onset of psychotic disorders such as schizophrenia can often happen a year or more earlier than they would normally have an onset if somebody is using cannabis. One thing that I found interesting when I was looking into cannabis a little bit more is that actually there's some evidence that the inpatient stays that people have are actually shorter when people come in with a positive urine tox screen, in part because I think it reflects the level of psychosis or mood disorders that can be induced by the cannabis. Methamphetamines as well, just to touch on them, central nervous system stimulant, their use has increased dramatically, huge increase. And again, the 2010s. And one of the concerns that had come up in the last decade has been the increase in opiate and stimulant deaths, that people will be using opiates, but stimulants to keep them awake. And the stimulants will often wear off before the opiates, leaving people in a place for significant risk of overdose. There's a high risk of dependency and a lot of co-occurring use of other substances. I just put this here just as a kind of general graph to look at overdoses and the significant increase here through 2019, just the significance of the risk of methamphetamines in terms of severe outcomes from mixing substances. I thought I would just quickly touch base on magic mushrooms as well. So psilocybin is the active content or compound in them, and it's converted into psilocin in the body. It causes up to usually about 6 hours or more of visual, auditory hallucinations, synesthesia, where you might feel a color or the mixing of senses. It was actually legalized in Oakland in almost 5 years ago, and in Santa Cruz about 4+ years ago. There was actually, there's been a significant increase that we've seen in people with mushrooms. Unfortunate situations where there have been overdoses, where people have thought that they could, there have been some more either suicides or deaths while people are under the influence. We've actually recently seen more people, I don't know, for those of you, just in June this month actually, the FDA put out an alert about microdosing of specifically the Diamond Shrooms brand of mushrooms. It's actually not psilocybin, but there's something in there. They're not quite sure even what it is yet that can cause some significant symptoms. We've seen people on the inpatient unit recently with an increase in the number of mushrooms. We've seen 2 people with microdosing of chocolate. I think one of the concerns for some of the legalization issues have been that we've seen people that are younger and younger having access to more items that can make people really sick and with psychotic symptoms that are harder to treat. I think maybe what I should do is ask if there are any questions. I can talk a little bit more, but maybe let me open up the floor to any questions that people have. Let's see.
Rena?
Yeah. Okay, so I'm just gonna go over the question. Just give me 1 second. Okay, so the first question is, how do you deal with comorbidity of substance abuse and eating disorders?
Yes, I think this has been a difficulty when there are a lot of new treatments for the eating disorders. And it used to be that stimulants, for example, some of the Vyvanse has been shown to help with binge eating disorders. So oftentimes with stimulants being used to treat eating disorders, if somebody has a comorbid substance abuse issue, it can be quite difficult. I think in terms of, I assume that means more of the binge eating disorders or is it also of some of the restricting disorders? There have been a lot of other treatments. Okay, both. Great. There have been we haven't seen as much of that on the inpatient unit because I think of the way that the stimulants have been controlled, at least the prescribed versions. We now have a cures report. So there's a report, a database that's held by the state of California that we need to, as doctors, check if we're going to prescribe any of more than 5 days of a controlled substance. So that has been a big improvement, I think, in making sure that people who are abusing medications or have a substance use disorder and are using it for eating disorders, that there are other options. I think where we get into problems, yes, if the stimulants have been really helpful for controlling food intake, but I think with now some of the new obesity medications, Wegovy, things like that, that can definitely help. So there have been other treatments that I think that are open to people in order to treat the eating disorders. So I haven't seen as much of that as a problem. We making sure that people I worry about with blood pressure or other things with the stimulants, making sure that people are managing cardiac risk factors and so on. So I think there's been a balance in that. I'm not sure if I quite addressed that question, but.
Thank you. Thank you for answering that. The next question is, can improperly diagnosed ADHD meds elicit psychosis in someone who is susceptible?
Yes, that's actually something we worry about. That's something that we need to watch for. Certainly ADHD meds are available and there's been a significant increase actually in use of ADHD meds throughout COVID. There were a lot of people, they've been a hot topic of conversation. Been a lot of actual difficulty getting the medications from pharmacy for people with the diagnoses. So I think that falls a lot to the prescribers, that if you're prescribing a stimulant for somebody, to be able to watch for that, to make sure that people don't have psychosis, to be able to be watching carefully your patient population, making sure that people aren't developing symptoms. Certainly when people are getting medications illicitly or off the internet, it can be difficult. Family members need to watch for that. And it can be quite difficult when someone has ADHD and starts to have psychotic symptoms, because a lot of times people will, it's hard to, sorry, I realized my computer just came unplugged, sorry. With ADHD, if somebody is starting to develop a psychotic disorder, the indication would be to stop the stimulants. There are other alternatives for people when they're developing psychotic symptoms, but I think we need to be careful, and I think monitoring, I would say, would be the biggest issue, to make sure that we aren't treating people inappropriately.
Thank you. Thank you for answering that. The next question is, after 6 medications and 20 ECD sessions, what other options are available or being investigated to address auditory hallucinations, that is voices?
That's a really hard question. I'm actually, where I do ECT at El Camino, we have a strong ECT service, and certainly ECT is a treatment of choice for treatment-resistant psychotic disorders that haven't responded to medications. I assume the 6 medications would probably be the antipsychotic medications. Usually, what I would say in a situation like this is, I always look, I guess, let me step back and say, when I'm looking at someone who is having symptoms that aren't responding, I always want to be sure, are people taking their medications? Are there other avenues? So most of the treatment, for example, for auditory or visual hallucinations would be the atypical antipsychotics. That's kind of where we first start. The things like Seroquel, Zyprexa, Latuda. Sometimes we'll go through multiple ones. If somebody's not responding to some of those, 3 or 4 of those, often we'll add one of the typical ones, something like a Haldol, Prolixin, some of the older but really good medications. I think if somebody's tried 6 medications and ECT, what I might look at that point is, Clozaril. I don't know if that was one of the 6 that had been tried, but for example, there are some medications like Clozaril that require a little bit more observation and monitoring, but can be really helpful. So sometimes the medications that you might come across in trying the first ones may not be adequately effective, but working with your doctor to do that. Sometimes I look at that point at some of the longer acting injectable medications. Sometimes there can be situations where people aren't responding for reasons like that. But I think that's the part where looking at the medications, making sure that there aren't any other comorbid substances, and working with the doctor. But that's a hard thing. ECT is one of those treatments for treatment resistance, and then some of the higher level medications too that can be really helpful.
Thank you. Thank you. Would a 988 call that needs 5150 ever end up at El Camino or only a county site?
That's a really good question. I don't know specifically the answer to that. I feel like that there are certain areas for ambulances, obviously, depends on where you are. If you're being picked up, if you're being transported, certain ambulances will go to certain emergency rooms. So there's, depending on, we are at El Camino, an LPS receiving site. So if somebody's placed on a 5150, the Lanterman Petrus short rules apply. So that would be the 5150. We receive ambulances at El Camino. There are some crisis stabilization units that people can go to. So I think if somebody is wanting help for a family and wanting to call 988, I think at that point, depending on the seriousness of the illness, whether somebody needs a short 24-hour stay, whether they need to be evaluated in an emergency room, but people do, I don't know specifically what the 988, how that ends up at El Camino, but I think anyone who's been in an ambulance, if you would get transported to the local emergency room. So sometimes either EPS, El Camino, Stanford, there are a number of you have to be a hospital that receives the 5150 so that we can manage and have a psychiatric unit follow up.
Thank you. How do you deal with a patient suffering with catatonia for 3 weeks and not eating?
That's really hard. The catatonia is a very interesting disorder because it's changed over the years. Before there were antipsychotics, a lot of times there were different versions of catatonia than we see now. Previously, there was more of a manic version, and then the kind of the catatonia that we think of where people are kind of stiff and unresponsive in terms of this question. So when we get somebody that has catatonia, the first treatment of choice would be Ativan, benzodiazepines to help. They can sometimes help the catatonia. Sometimes the antipsychotics can also help. But by the time you get to someone who has been 3 weeks with not eating, right, we're by that point, I think the doctor has gone through the benzodiazepines, has gone through antipsychotics. ECT is actually indicated in that situation. So what we would usually do by that point, somebody's been on a medical floor. If they're not eating and they're not drinking, if they were on a psychiatric unit and originally, they probably would be moved to the medical unit in order to give them fluids and to give them food and nutrition. We do have, for example, at El Camino, there's a consult liaison service, and the providers will make sure that the patients on the medical floor are taken care of. In that case, one of us, probably a psychiatrist, would be called in to evaluate for the appropriate of ECT. We would only do something like ECT in a situation where the family was supportive. You'd need a court order in order to do ECT on a catatonic patient who was not eating. You would need at least 3 psychiatrists to sign off. So there are a number of steps that we would go through. We usually try to use the medications, try to reverse the catatonia, and make sure that people are getting the adequate nutrition. So making sure they're getting food and nutrition, and then really working with the family to consider what some of the other options are.
Thank you. The next question is, how do you deal with a patient who has cannabis withdrawal symptoms?
So this is we're seeing a lot more of. Originally, people didn't think that you could have withdrawal symptoms, that you could have dependence, and what we're seeing is that you can. People often can get very anxious. So using medications that might help control agitation, anxiety, the atypical antipsychotics, medications maybe such as Seroquel that would be sedating, that would be helping people to calm down. Oftentimes people can get, either agitated, or people can have withdrawal symptoms and feel really ill. Most of the time for us, I think what I see on the inpatient unit is that the cannabis, for the most part, when we see the withdrawal, I see the agitation, I see the anxiety, I see the lack of sleep. A number of people are using cannabis or CBD compounds for sleep, and it's made it a lot harder to then go without. So I usually would start with either things like Seroquel, something that would be more sedating, or standard medications to help with sleep. So kind of managing the symptoms. If they're not sleeping, trazodone, Vistaril, hydroxyzine, some of the medications to help people sleep, medications for anxiety. I often use gabapentin actually for help with like alcohol withdrawal, because it tends to help with anxiety. It can be hard because we don't want to use too many other substances that are addicting or contributing if there's a substance use disorder. So some of the benzodiazepines may be harder, but certainly in short-term use and when people are in the inpatient unit, it makes it a little bit easier to manage. Oftentimes we always have to make sure, is it just cannabis they're withdrawing from? Are there other things that might be contributing? But some of the anxiety management skills and techniques.
Thank you. The next question is, when you have a dual diagnosis, which one do you treat first?
For me, where I start is I want to make sure people are safe. So if somebody is coming off of, for example, alcohol, we have to make sure that the alcohol withdrawal is safe. If somebody is coming off of opiates, we have to manage that. I think people can have depression and use substances and have substance use that creates depression or psychosis. So for me, the abstinence has to be where we start, but we do them together. So if you're abstinent, but you've been using alcohol for anxiety, or you've been using cannabis for sleep, or you opiates for pain. We need to figure out some other way to manage those symptoms. So kind of depending on the level of severity, we would pick an environment. So I kind of start with the environment. If somebody needs safety, if we need to get you off of benzodiazepines or alcohol or something that could cause serious seizures or cardiovascular problems, we would consider inpatient, some sort of controlled environment where you can take somebody off of a substance, but we also have access to be able to help you with sleep or help you with nausea or help you with pain. There are a bunch of outpatient programs where it can also be done where you get the mental health. We have a dual diagnosis program at El Camino that is the PHP level and IOP. So PHP stands for partial hospitalization program. So normally if someone were coming in and they didn't quite need an inpatient or residential level of care, but really needed the support to have that mental health component while they're staying off the substances, something like the dual diagnosis PHP program, which is 6 hours a day, 5 days a week, is really helpful for that, because then it provides you the mental health treatment, the groups, the anxiety management, but also talks about the substance use issues that come up, why you're using the substances, the negative impacts they can have. Because I think oftentimes I'll see that in depression, where people say, well, I can't get off that because I'm so depressed. It doesn't matter. I'm going to stop. I'm going to stop and I'm still going to be depressed. And in talking to Dr. Garner, who's one of our substance use experts and runs the dual diagnosis program at El Camino, it seems like they're about half of people that just get better with the sobriety. So in the combination with the treatment with mental health, for ECT, for example, we want people to be off of cannabis or off of substances for about 30 days, at least enough to have the mental health condition be treated. When people are actively drinking, alcohol is a CNS depressant. It can cause significant depression. So I feel we have to kind of start with the sobriety, but we also need to do it in a kind of safe place.
I'm just going to jump in for one quick second, and skip to a question, because we've talked a lot about ECT, but I see somebody is asking what it is.
Oh yes, okay. So let me touch
Yeah.
base on that. So ECT stands for electroconvulsive therapy. People used to know it as shock therapy. We don't use that word anymore because it's a very ECT, or electroconvulsive therapy, is a very different treatment than it was 60 years ago, or even in the 70s or 80s. And most people know about, I think, ECT from One Flew Over the Cuckoo's Nest, and some of the media examples and demonstrations of ECT. I have a whole talk I could give you on ECT, but basically it is a medically, we in ECT, we have people have anesthesia so that they're calm and not aware of the process. And we apply electricity via electrodes to the scalp, and it induces a seizure that's controlled. So we have anesthesia so that your body is calm, you're calm, and the seizure can help treat a number of conditions like depression, especially treatment-resistant depression, psychosis, catatonia. It's actually the treatment of choice for pregnant women. It's actually safer for babies than some of the medication options. But so ECT has been around for a very long time and has a bad rep in the media. There was a study about 25 years ago where they looked at about 2 to 3 dozen instances of ECT being mentioned in popular culture, and they were all wrong. There's been a huge growth in the technological advances and the way we do the treatment, but it has ECT has a success rate for people that mirrors what you would try for like your first antidepressant. So somebody who's never had depression before comes in and gets Prozac for the first time. ECT is usually used for people who've had multiple medication trials or extremely suicidal or treatment resistant conditions. And it has a success rate of people recovering from their severe treatment resistant symptoms that almost surpasses that first antidepressant. So it's a very, it's the most effective treatment we have in psychiatry. It's just because of the way that when it came around in the last century, it was used in a lot of situations where people were really ill, and it was used in situations that weren't protected by the laws. Now in California, it's the most regulated procedure in California. It's safer than getting your tonsils out. It's done under anesthesia. We have 2 doctors. Any patient wants to get ECT, they have to go through 4 doctors to approve every 30 days in the state of California. And every quarter we go over with another 3 doctors. It's a very safe procedure. It's, for me, just to give one example, that kind of refers actually back to the catatonia. The reason I got interested in ECT was when I was a resident, first month on the unit, the psychiatry unit at Stanford, and somebody who had been there for a couple of months, not eating, dying, basically not eating, not drinking, not talking, not moving. They had to get a court order to get the patient treatment. And he came back from his first session of ECT. The seizure is about 30 seconds, 30 to 60 seconds. It's a fairly quick treatment. And he came back and screamed at me and called me names and asked me why I hadn't saved his breakfast. And it lasted for a few hours and then wore off. And he went back to his catatonic state. And over the course of the next 2 to 3 weeks, he completely recovered and was able to go home. So there are certain treatments that we have in psychiatry that where there are ways to help people get better that we didn't have 20, 30, 40 years ago. We have medications that we didn't have. We have psychiatric units where people are taking care of you. And I think where ECT has moved is to treating, yes, refractory depression that's not effective. So if you've had Prozac, Zoloft, Lexapro, Celexa, Cymbalta, Wellbutrin, you've had multiple antidepressants, and you're still severely depressed, not responding to treatment, wanting to die, suicidal, it is a treatment that people can get both inpatient and outpatient. So I probably talked too much about that, but it's a treatment that is the most effective treatment we have in psychiatry for some of the most resistant diseases and illnesses.
Thank you so much for explaining in detail. Thank you. Really appreciate that. The other question is, since my son, 27 years old, doesn't want to see a doctor and he's not diagnosed yet, what can St. John's wort help?
So there's some indication that St. John's wort can help with depression. And there are certainly a number of things that can help people who aren't quite ready to seek treatment. Things like exercise, dietary changes, sleep. But I guess where I come with that, it would depend on what somebody wasn't getting treatment for. I always looked at what are the symptoms that someone's having and what did they want to change. So if somebody, for example, is depressed and wants the depression to get better, or if they're anxious. So somebody who's 27 who doesn't want to seek help, I guess I would look at it and say, what are the symptoms that they're having? What are the things that they want to get better? Is there something that this illness is preventing them from doing in their life? Because sometimes there can be a hidden anxiety component. People can stay at home or things aren't working, or they get depressed because of, underlying social anxiety, or can have trouble in work or other issues because of depression or anxiety. So to me, I think it's the communication. So finding out in this particular situation, for example, trying to find out what's going on, what you can do. One of the things like in that situation that I would say that's maybe not what I've addressed is sometimes family support is sometimes being able to model that behavior and say, I'm going to go see a therapist, or I'm going to get a Zoom therapist and I'm going to see someone. and inviting that person along. Sometimes that's the way to open up the communication, because I think getting out there and talking to somebody, whether it's a peer, whether it's someone through NAMI, whether it's a therapist, getting that communication started, that to me is where I would start in a situation like that, because there may be something that's going on that can be helped. But yeah.
Thanks for answering. And I just want to add on that, you mentioned NAMI, we do have a program for family members. It's called Family to Family. And this is something that you'll meet other family members who've been in a similar situation. Maybe their loved one hasn't been diagnosed. So they learn the communication skills. They learn exactly what resources are available and how do you deal with that. So that's one class that you might be interested in, and you can call our helpline number, or the loved one can join peer-to-peer, which is a class where they can go and learn more about their diagnosis and get support. So I think coming to NAMI would be really helpful, and feel free to give us a call.
Because I think that, yes, family support and I think the awareness. And if you've got somebody, I know that NAMI volunteers and representatives come to El Camino, for example, and talk with patients. And that's huge, because to be able to see someone else who's had something or has an issue that they're willing to share and communicate, I think it's very it helps people open up to recognize that you're not the only one. Because I think that's a big issue with mental health, is you feel like I'm the only one. Fortunately, I think COVID helped open that up, and it became kind of a national conversation. But even if there are, I could actually maybe give you the number. I could put it in the chat. There's a number for access. So El Camino also, NAMI is fantastic. And hopefully you'll share all the resources. If we want to look for something, the inpatient or outpatient level of care, El Camino has a number that it's for the access team, 650-988-8468. I'll just type that in there. So El Camino, for example, has a number. You can call the access team and they will help you navigate where to go. They like the person who's having the symptoms to call, because I think you're much more likely, when you're the one who calls, then you kind of give somebody a sense of agency. People can really feel like they're getting somewhere. But as a good place to start, the navigators at El Camino can kind of help figure out in a phone screen, is this something that requires inpatient? Is this something that might work with one of our 3-hour-a-day programs or 6-hour-a-day programs? Is this something where you're looking for referrals for an outpatient psychiatrist or therapist? And we can kind of give you that guidance and help you figure out. We at least at El Camino, we have a whole gamut of programs and in fact, maybe I could even, if I just share my screen real quickly, showing you some of the programs that we have in terms of adult and youth. So we have an older adults program down here, OATS for 55 and up, everywhere from middle school and teen programs, Quest to involve with addiction for children, transitional age youth like 18 to 25. We're dealing with a lot of issues that kids this age and who've kind of grown up in the COVID era of trying to make that transition to adulthood. And it's a really difficult age. The adult mood program is from 18 and up, outpatient programs from like 3 hours a day to the 6 hours a day. There's a new LGBTQ pride track for people who want to explore and have more support in those issues. Addiction services, we have an evening chemical dependency program. Continuing care program is an IOP, the part day and full day PHP programs for more specialized thought disorder programs. A lot of the outpatient programs at other places are more for just a depression or just anxiety. And actually El Camino has one that involves more thought disorders, for psychosis, for bipolar illness, that needs more support and individual care, dual diagnosis we've talked about, even moms. So, and I think where we have, and then inpatient, We've talked about that. But they're definitely, sorry, I think I've lost track of where we were, but there are lots of services. And I think getting people started, making the phone call, making the connection can be a really good start.
Thank you. Thanks for sharing that resource. Okay, next question. I'm curious on your thoughts in the recent years on occurrence of women being late diagnosed with autism who were misdiagnosed as bipolar, BPD, etc. for years prior.
I think that is a fabulous, fabulous question, because that's what I've been seeing in the adult mood program. I did the adult mood program for about about 5 years, which is the PHP and the IOP program. And I've seen a huge number of people arriving at, 18, 20, even 30, 35-year-olds who've never had a diagnosis of autism spectrum. Before, it used to be autism and Asperger's, and there kind of wasn't this understanding in the community of all the variations of that whole spectrum. In our new diagnostic material, we refer to it as autism spectrum. It's kind of unclear exactly what's contributed to that increase. I don't know. Some of my personal thoughts are with this area and the large portion of people in tech and just the growth in this area. I think there are a lot of situations in which some of the characteristics that fit onto the autism spectrum are really helpful, or in tech or computer, or the ability to communicate and focus. There are a lot of, I'm not gonna I get too excited about this. I've seen a number of people, to go back to the question, a number of people who were never appropriately diagnosed. We have a shortage of testing options for people, and I think it's hard to get neuropsych testing without referrals and just the intensity of the testing. But there's been a huge increase in the number of people wanting to get testing, the recognition of some of the symptoms. And I think people do get misdiagnosed. I think it can also lead to situations where people have depression that doesn't seem to respond to the usual treatments. So people might get bumped up to, multiple medications, or ECT, or other issues, because the depression and the underlying things weren't necessarily addressed. Or some of in some of our programs, for example, the Aspire program in teens, there's a larger portion of the kids, we do think, that we're seeing autism spectrum diagnoses being made. Want to be very careful not to make a diagnosis if we haven't done official testing. But I think, to the questioner's comment, I do think I've been seeing it significantly more, and there are a lot of things that we can do to address it. There's a special type of DBT therapy that's directly can help with autism spectrum. So there are more treatments as well as diagnostic things that can be done.
Thank you. Okay, moving on. Are there newer meds for treating schizophrenia? After 8 to 10 years, my daughter is overweight and bothered by involuntary movements. She takes Zyprexa and an upper.
Yes, I think there have been a lot of, new medications. Some of the medications, though, are new versions of the old medication. So there are medications where they'll change part of the molecule and make a new medication. Risperdal became there's a version of Risperdal that's in Vega, or Abilify. They'll have longer acting versions. But since Zyprexa, there are a lot of new ones. So Zyprexa, Seroquel, Abilify tends to have a slightly better weight profile. Latuda, I've seen do well for people. Geodon, Vraylar. There are a number of new ones that each tend to have different characteristics. That's one of the things that we do as a psychiatrist, is that trying to pick the medication based on the efficacy. Zyprexa is a really, really good medication. It treats the symptoms really well. But there are a lot of side effects that some people experience that you're talking about, like metabolic side effects, weight gain, blood sugar increase. I think with the new weight loss medications, we're starting to see more people with some of the injectable weight loss medications like Wegovy or Ozempic, and utilizing those in patients with psychiatric symptoms. I'm not sure where we've gotten yet on the insurance coverage for some of those medications, but I think there are other options. It's hard when you have some of the medications that are less likely to cause the metabolic side effects, like the weight gain, the blood sugar elevations, and so on, often can cause more of the physical, the motor. So the ones that tend to cause the metabolic things tend to cause less of the movements, and the ones that cause fewer of the metabolic tend to cause more of the movement issues. So I think it's working with your psychiatrist and trying to find an option. You definitely want to make sure it's working, because I think that's the number one thing. If it's not working, then I worry a little bit less about side effects. I want to find something that works, but there are ways to adjust that. There are medications for whether it's adding metformin, adding other like diabetes type medications to help with the cravings. It's always hard when I think to the stimulant question that came up with the eating disorder, that actually sometimes comes up for people with schizophrenia or psychotic illnesses, is can I use the stimulant to help with keeping my appetite down for the antipsychotics that I use for my psychosis? That's really hard because sometimes the stimulants can actually induce mania, they can induce psychosis. But I think certainly there are newer medications that can be used, and it's definitely worth speaking with somebody who can help with that.
Thank you. How would a provider manage a patient with a Clozaril and continue to use cannabis?
That's really hard. I think because cannabis is legal, it makes it difficult to control. I'm always worried when somebody is using an antipsychotic medication for psychosis and is taking something like using cannabis that can contribute to the symptoms. My feeling is that if the Clozaril is needed, then ideally people would be off the cannabis because they can counteract each other. So yes, I have trouble with that. I think there are some Clozaril is, just to fill in other people, Clozaril is one of the antipsychotic medications that is the most effective, but it has some potentially serious blood side effects. So it has a high level of monitoring required. When you first start the medication, you need to take blood on a weekly basis to make sure that you're medically safe. So some providers won't allow people to take a medication that has potentially significant side effects with something like cannabis that could induce the symptoms or make them worse. I think it's hard to control because it's legal, it's available, but I think it's something that the provider and the patient and the family would usually take into account. Is this the most effective way, or is there some other way that what is that cannabis treating? So that's something I always look at, is why are you smoking? Why are you vaping? Why are you using the edibles? Is it, some people use it for entertainment or to get high, or they like the effects. Other people report that they're using it to manage anxiety or insomnia or other things. The problem with cannabis, it can actually increase nausea. So some people are taking it to calm their stomach, but it can increase nausea. I'm always a little bit uncomfortable with having somebody who's got a psychotic illness or who has symptoms that are difficult to treat or treatment resistant, which is what usually Clozaril is for, if somebody's using something that could make their symptoms worse.
Okay, I'm not sure if you can answer this question, but the question is, does El Camino accept Medi-Cal insurance if she's with Momentum and is a member of Valley Hospital, we're not staffed, we're not satisfied. We want to change to El Camino Hospital if we can. Thank you.
Yes, El Camino accepts most all insurances. We accept Medicare, Medi-Cal, most private insurances. There's actually a state law, Assembly Bill 72, AB 72, that requires hospitals or insurance companies to pay doctors, for example, if you're at an in-network facility, as if you at an in-network facility. So if you come into an emergency room, there are other laws too, EMTALA laws that require patients to be treated. You actually don't get asked for your insurance when you first check into the emergency room. When you come to the emergency room, for example, it's your illness that's treated. That's the emergency. That's why you're there. You get treated. In terms of expanding on that question, there are some programs like inpatient, for example. We take Medi-Cal. I'm a Medi-Cal provider on the inpatient side. Some insurances don't contract with El Camino for the outpatient treatments. I know that Medi-Cal, for example, does have a program for the Aspire program for the child and adolescent programs. Their Medi-Cal is accepted there. I think some of the Medi-Cal programs are not accepted in the intensive outpatient programs at El Camino, but definitely on the inpatient hospital side. So what I usually recommend is you can always contact the Access program, ask about the insurance, try to find out what level of care you're looking for and whether that's covered.
Got it. Have you seen that vaping leads to cannabis?
So in terms of the vaping leading to a cannabis, in general, when kids, I'm not sure that I've seen it specifically. So sorry, let me rephrase that. Yes, I think if kids are smoking and they're in an environment where they're smoking, the flip to using cannabis is much easier. Certainly, I worry just in and of itself about vaping and nicotine for kids. There are a lot of things that vaping, a lot of negative side effects that are coming out, a lot of negative side effects to tobacco, and certainly developing a dependency and the way that the brain changes when people are young. I think there's been a lot of cannabis use that started in schools and in young age groups anyway. So my feeling is certainly I would prefer no one vape. I think vaping has been shown to be harmful for your lungs, has been, I guess for me, trying to figure out what are the symptoms that, what started you vaping? Is it because your friends were doing it? Is it because you had anxiety? Was it cool? Or now do you have an addiction to that? And for cannabis, and kind of looking at that too, and recognizing what are some of the ways in which one addiction can translate. If you're treating anxiety, I think there's definitely a link. If you're treating anxiety with the cannabis and going up in terms of other drugs is definitely yes, and certainly we see a lot of vaping in some of the adolescent population. We want to make sure to manage a little bit better. But I hear the concerns, and certainly I don't know if that's from a parent or from someone who's vaping, but I always want to be careful about what comes next. I think, again, cannabis is actually becoming more prevalent in than alcohol because it's easier to get. You can get it. You can't get alcohol until you're 21. More people do have alcohol. People do have cannabis, but I think it's certainly. I think for me, it's the nicotine as well.
Got it. I learned that one of the lasting effects of meth use is paranoia, as well as some with marijuana use. Have you noticed any trends with this? How would you treat the paranoia?
Yes, that's one of the things we see substantially. And I think one of my concerns about the use of either methamphetamines or cannabis, is that there are people where sometimes there's a genetic susceptibility. Why does one person use alcohol, for example, and it affects their heart? Why does somebody else it affect their liver? Someone else it might affect their brain. So I think that there are some parts where there's a genetic susceptibility to why is one person likely to develop paranoia or auditory hallucinations, psychosis. So there are some genetic things that make someone more likely to develop a psychotic illness or paranoia. And certainly I've seen that in people where I've had a number of cases I can think of, just even in the last 2 months. I can think of 3 or 4 people who had just first time use of a substance and developed psychotic symptoms on the inpatient, and we're on the inpatient unit for the level of symptoms. I worry not only about kind of the development of the paranoia, but also continuing. So sometimes when people if they stop the use of the methamphetamines or the marijuana and cannabis, sometimes the symptoms will go away. We usually would treat symptoms like that if it's just the paranoia with the atypical or typical antipsychotic. So someone might have a little Zyprexa or Seroquel. Sometimes Risperdal can be helpful because it tends to be less sedating and have fewer metabolic side effects. Latuda, I've seen help with that. Sometimes that paranoia can continue, and then people will need continued treatment. Other times the paranoia will resolve faster. As I mentioned, there does seem to be a trend where sometimes the hospital length of stay can be a little bit shorter if somebody actually has a positive tox screen, because of the impact of those substances in making people's symptoms worse. So people may come in, but once the substance clears, the paranoia may go down faster, or the manic symptoms may go down faster. So I think the concerns about if somebody's using those drugs and they're having, or the compounds, and they're having paranoia, being able to get the symptoms under control, whether it's by abstinence, by the atypical antipsychotics, or whether even sometimes anxiety medications just to bring the anxiety down, which can also fuel things. But usually it's a matter of sobriety and hydration and sleep, and making sure that people's moods and rhythms get back into. One of the things that can happen is that when you're using a stimulant, for example, sometimes people have trouble sleeping, and sometimes the lack of sleep can actually fuel that, either the psychosis or the paranoia. Just the lack of sleep can really impact people, either in a mood perspective or in the psychosis and the hallucinations. And so find it's very important to make sure we sobriety, sleep, and medications as needed to treat the symptoms.
Okay. How do you treat tardive dyskinesia? What is your opinion on the new meds to treat this condition?
I haven't used the new medications as much. I've had one patient who's on them. My feeling, so tardive dyskinesia, let me just address tardive dyskinesia. It's a movement disorder that's usually associated with the use of the antipsychotic medications. So the medications that kind of block dopamine, that help with visions, hallucinations, that can help with mood. When used for a longer period of time, it's usually associated with the amount of use and the length of time that you're using them. And tardive means kind of late. So late onset, and dyskinesia, a movement disorder. So you often can get movements that look like the common ones that I see are facial movements. So people puckering their lips or moving their tongue. Sometimes you can have, it can look like tics. The problem with tardive dyskinesia, true tardive dyskinesia that develops after a long period of time, is that it can be a permanent condition. So it's the body's it's gotten sensitized to movements, and so it has these movements that happen on their own. There are a number of movement disorders that occur sooner maybe not so long, that can be reversible. Sometimes there are there's some medications that are less likely to cause that. For example, Seroquel is less likely to contribute to that. Clozaril is less likely. So if somebody has tardive dyskinesia, one of the first things I look at is, do they still need to be on those medications? And sometimes the answer is yes, somebody has an illness that requires those medications. And what we need to do is figure out how not to make the tardive dyskinesia worse. If somebody develops symptoms right after starting a medication, it may be something different than tardive dyskinesia per se. But there are new medications that are coming out that are attempting to treat tardive dyskinesia. We used to see tardive dyskinesia a lot more, even more than we're seeing it now, because previously the antipsychotics that we had were the typical antipsychotics, the things like Haldol and Prolixin that were more likely to cause some of these side effects. So people who'd been on them for 20, 30, 40 years had more significant symptoms. We're still seeing a lot of it. Some of the medications, they're trying to make medications like Abilify. The idea was maybe it wouldn't block the dopamine completely. It would leave some of it the way Abilify affected the receptors, that maybe it would be less likely to cause tardive dyskinesia. I have seen people with Abilify develop tardive dyskinesia, and with kind of all medications. There are certain things that tend to make people more likely to get tardive dyskinesia: extremes of age, slight female to male, long use of the medications. I guess to answer the question, I would say yes, I think it's worth trying some of the new medications. I haven't had as many of the people on them on the inpatient unit, but I think they can be very helpful.
Okay. Let's see. Are there any natural remedies to treat depression for someone who does not like to take medication?
Absolutely. I mean, the first thing I would say is exercise. Exercise has been shown to help women. There are many studies with women, with men, with exercise. So getting out there and getting sunlight, exercise, sleeping well. They've even done studies where they'll have a pretend study where they'll give half of the group a mood log and ask them to rate their their mood while they're waiting to get into the study. And other people, they'll just wait for a study. Even just the act of recording a mood log has been shown to help depression. So mood logs, exercise, sleep, healthy diet, communication with people, getting out of the house. Pets have been shown to help with depression. Certainly therapy, talking about things. There are a number of options, either online, in person, finding therapists. I think that in person tends to work better. I do mostly Zoom for my patients in the outpatient world when I'm not on the inpatient unit. But I think seeing people in person is huge. Going out with friends, making contact with supportive family, having, like with NAMI, having a mentor, having somebody where you can really focus on, I want to get myself better. I want these symptoms, identifying what you want to improve and what you're going to do to go about it, and getting support for that, I think can be huge. So I think there are a lot of options that don't necessarily involve medications. I think medications help get people there faster. And a lot of times I think sometimes faking it till you make it actually does work. Placebo has a 15%, so you believing that you can be better has been shown to be helpful. When it's not, I think medications in combination with those other things can be helpful. But, do I want somebody to just give somebody a medication while they stay in bed? No, I'm usually telling them to get out, go to the mailbox, walk up and down the street. So I think, yes, there are lots of things that can be done to help with depression.
And you mentioned having a mentor, and I just want to mention that NAMI, we have a mentoring program called Community Peer Program, which really helps. And El Camino actually did a study several years ago, and through the study, we saw that rehospitalization for a lot of patients reduced by over 85%. If you are interested in the Community Peer Program, you can go to our website, fill up the form, and then get in touch with us. Okay, I'm going to move on. We're taking the last three questions now because we're getting close to 8:30. So the last three questions. How soon after taking Geodon, I'm saying it correctly,
Mhm.
can we see improvements? How do we know if the patient is taking the right medication for schizophrenia?
Very good question. So Geodon sometimes can help right away. So we often will, I've used it in the emergency room to give to people. There's an oral form and an injectable form. So oftentimes people will respond very quickly. Sometimes it takes a little bit longer. So finding the right dose can go up to 320 milligrams. So sometimes people only taking 40. Sometimes it's finding the right dose. And it may take a few weeks, but usually if I haven't seen somebody having some response, then we want to consider either other options or augmenting it or increasing the dose. And I apologize, the second half of the question there was let me see, where were we? With how do you, was it how do you know if the patient's taking the right medication for schizophrenia? So my hope would be that the symptoms would be managed. So that I think is the real question is, oh, how do we see the patient is doing? Are the symptoms that they want getting better? It's a lot of the times we choose a medication based on the side effect profile. Again, if somebody needs some sleep, we might give them one that's more sedating. If somebody wants one that, and they're very anxious, we might give them one that helps also with anxiety. Sometimes we like picking antidepressants, for example. There's so many of them. People say, what's your favorite? And it really depends on what the symptoms people are having. If they're anxious, I might have this one. If somebody's eating too much, I might do that one. If somebody's not eating enough, I might do that one. So I think, is the thought process working? Are the voices under control? Are they able to sleep? Is the suicidality, is there any suicidality? How are they functioning in the community? Are they able to go to work? What else do we need to do to help people? Like, what are the symptoms? So for me, I think when trying to figure out if it's the right medication is working with your provider and finding out what is the thought process. Sometimes when I talk to somebody, I want to hear what their thought process is like, so I can understand what they're seeing around them. Are they functioning where they could be? Do we have the right medication? So I always want to look at the symptoms and make sure that somebody's taking care of those.
Okay. The next question. I learned that in the state of New York, they are testing all people that are present with psychosis for autoimmune disorders. As it appears, there can be a causal relationship. Is California or El Camino Hospital also starting to consider this?
I was not aware that they were doing it in New York. I think that's a fabulous consideration. Usually for us, we don't necessarily start with that. I think it's always something to keep in mind. There are a lot of autoimmune conditions that can mimic psychotic illnesses. And so when we have somebody, for example, there are some NMDA receptor encephalitis, inflammation of different parts of the central nervous system of the brain. And we'll often see we will often have people who have that arrive on psychiatry. And there have been some situations where they've bypassed the emergency, or they've been cleared in the emergency room, and we didn't recognize that. So I could see that would be something we would start to screen for. Historically, it's been very expensive. If the panel's $5,000, if it might take a couple of weeks to get a panel back, there are certain things as well we look for. We do a basic blood count. We want to make sure you don't have signs of inflammation or infection. We'll check a urine. Somebody who has acute onset of depression or delirium or psychosis, and an 85-year-old woman is probably a urinary tract infection before it's a psychotic illness. So there are certain things that we do look for when we clear. We have everybody who comes to psych at El Camino, for example, they go through usually the emergency room, and we try to make sure. If it's a first break psychosis and we don't have an explanation, we might do a head scan. The likelihood that we're going to find a brain tumor or an autoimmune condition, they're a lot lower frequency, unfortunately, than the number of people that come in with cannabis or the number of people that are having new onset psychosis. There are certain characteristics that we can look for to help. If somebody, certainly we do a full scan of other symptoms. You're supposed to have a neurological exam to make sure we don't see anything neurological. If you have a really stiff neck, if you've got a fever, if your white count is elevated, those are things that might, but some of the other tests, like some of the autoimmune for lupus, those kind of things can often take a fair amount of time to come back. So sometimes if we check for those, we've already started to treat. If, however, somebody's not responding to the usual treatments, that's also another sign that something else is going on. So that's something, or if they have mental status changes, the confusion or the psychosis, there are certain characteristics that psychiatrists will look for where we say, this doesn't seem like the likely onset, or this history doesn't make sense to me. So we don't have as far as I know, a plan to institute that, but we do look for medical clearance. And when things aren't responding like we expect, I always want to keep that in mind and make sure we've really thought through what are other things that this could be. Because for me, as a psychiatrist, psychiatric conditions to me are the kind of, I want to have the medical stuff ruled out first, because the psychosis can be life-threatening, but in that moment, a heart attack, something else, I want to make sure they don't have an infection, that they don't have encephalitis, meningitis. I want to make sure they don't have those other things. And then I treat it. So a lot of times I treat the psychiatric component after I've tried to exclude all those medical things for that very reason.
Okay, we're on our last question here, and I think it's a follow-up on the earlier question about Geodon. So how long will it take to see noticeable improvements taking psychotic medications, Geodon? If they are still hearing voices, when would they stop taking that medication?
So my feeling is if somebody's still hearing voices, it kind of depends on how long and what the doses are and what the treatment is. I would definitely not want to do anything without talking to your psychiatrist, because there may be certain things. Some people don't absorb. For Geodon, for example, it tends to get better absorbed when you have a full meal, or when you're eating food that contains like lipids and fats, like cheese or peanut butter. So there's certain things that might make you not absorbing the medication or not responding to the medications. Usually we'll say if somebody has a psychotic episode in the hospital, and for example, we get their symptoms under control, we might actually say we should be taking this medication probably for 2 years to make sure we're not having a psychotic symptom. For depression, it might be 6 months once you're stable. If people aren't responding, I, as a psychiatrist, want to know, because either the medication's not right, there may be some adjustments I can do. But sometimes people will stop their medications after only 2 or 3 weeks. A lot of prescriptions, there are studies to show that people don't tend to fill that prescription at the first prescription, or they don't tend to complete even a month of the medication. So the number of times people don't even go for that second month. I would say if you haven't been back to the psychiatrist a few times, you probably haven't been on it long enough, because it can take multiple adjustments. And there may be, I wouldn't start somebody on the full dose of medications the first time I saw them. So it might take a number of visits until I was comfortable that we'd really tried that medication. If you are having side effects, absolutely talk to the doctor, because there may be some different medication. But if you've only seen them once, you've been on it a few weeks, you haven't been responding, it may be just a dosing issue, or the way the medication's being given, something else that's going on.
Okay, I think one last question just came up, and I think we'll end with that question. Is schizophrenia common or general? My son saw 2 psychiatrists, one through video and one in person, and only for 15 minutes. He was diagnosed with schizophrenia.
It's it's a fairly, from a psychiatrist point of view, it's fairly common. It's like schizophrenia is a disorder that involves often hearing voices or seeing things, psychotic thought process. It really depends. I'm always uncomfortable with the idea that somebody is diagnosing somebody just in 15 minutes without doing a full history, or but sometimes the history that you get can help you with that diagnosis. There are certain things that a trained doctor will look at and say, boy, this really fits the characteristics. This looks like it has this history, this is the onset, and all the history that somebody's given me really points in that direction. But I want to be very careful. You can't, if somebody's only had psychotic symptoms, for example, for a month, you can't officially diagnose somebody with schizophrenia. It's an acute psychotic episode, that you're not allowed to do that label. If somebody's had symptoms for 4 to 5 months, or when we get into 7 months, 8 months, the diagnosis is easier. We may suspect where things are going, or depending again on that length of time, there are specific characteristics, and there are specific time periods that we have in order to diagnose it. And I always want to work with families and really talk about that can be a big diagnosis. And so getting it and just being told you have schizophrenia and come back in a month, that families and patients need a little bit more. You need to be working with somebody you trust, because if the diagnosis is schizophrenia, it tends to involve a lifetime of that diagnosis, and you need the treatment, you need the engagement. There are things that can be done. I always want to make sure, if for example somebody's diagnosing somebody just on Zoom, did you do a urine tox screen? Is somebody taking something you don't know about? Did you have something? Were there some mushrooms? Was there some cannabis? Was there something else that might be contributing to this? So there may be a diagnosis that you can give based on the history, but I always want to be very careful about getting the medical information, making sure I've really done a good, thorough history. And if it all lines up, making sure that that person has the follow-up. So yes, it's possible to diagnose schizophrenia in 10 minutes or in 15 minutes. But I'd want to make sure I knew more in depth about that, because I think I'd want to give you more information about what you could do, because to me, the symptoms, it comes back to the symptoms. The diagnosis helps me as a psychiatrist or to know how to treat it, or it helps a family know, what is this going to look like in 1 year, 5 years, 10 years? What do I need to do to plan going forward? But to me, the diagnosis itself doesn't necessarily explain how the person is experiencing it. There are a lot of people who can enjoy, that can even some of the voices. One of the problems that we have in treating psychotic illnesses is that, or in even manic episodes, that sometimes being in that state, the person who's there doesn't recognize that it's a problem, doesn't recognize that they need treatment, doesn't feel the medications are needed. They feel fine, or they don't trust you, or some of the symptoms that the diagnosis causes, that the disorder causes, can make it really hard to get treatment. So for me, it's not just necessarily the diagnosis, unless it helps me figure out what medication or what research says to do what. But I think it's very important to get more support. And if you have a question where you don't like the diagnosis, to talk to your provider and say, this seems like you made a snap judgment. Can you explain to me why? And most psychiatrists and doctors would be able to sit down with you and say, here's why: the voices, the visions, and some of those issues, and can go through the symptoms with you so that it makes more sense, and so that the treatment makes more sense. Because I think there's a lot of hope. There are a lot of medications. There are a lot of treatment options. And sometimes it just really involves holding on and doing the treatment and getting there to the other end. Because a lot of times, again, when you're in that episode, some people don't realize they need treatment. And making sure we protect patients' autonomy, but also making sure that we help people that need the help to get through to the other side so that they can see, oh, when I'm not hearing voices, I feel better. Or maybe I don't feel better because I'm actually anxious now, but now I can treat the anxiety, or now I can work on the job, and now I can get that sense of community and I can reintegrate. So there are things that people do, and guidance that you can get and support that you can get that I think gives people a lot of hope, that helps me get away from just the negative of a diagnosis that gets handed to you in 15 minutes, because that sounds like it's pretty hard.
Thank you so much, Dr. Taylor, for answering all the questions in such detail. I think we really appreciate that. I think everyone stayed on, everyone had great questions, and you answered them so well. Thank you so much for taking out the time today and spending this time with us and answering the questions. Maureen, is there anything else you want to?
No, I just thought the last question was a fantastic wrap up for everything that you said.
Yeah.
Tonight. You know, it really just encapsulates, you know, that there is hope, and that no matter what the diagnosis is, and you work at it and you get the support, you can get to the other side. And that's what I think all of us want. So thank you so much for ending on that positive note.
Thank you so much.
My pleasure. Because I just want to commend NAMI for the, I know I've said it before, but really commend all of you and the community and the support that everybody provides. The fact that you're here, the fact that you're listening to this, that you have questions and that you're wanting to get them answered, I think is huge, because a lot of that to me is it's the communication and the networking and the community that there is hope. We can get through this. There are things that can be done. And if they're not right, let us know and we'll try a different plan. We'll try to figure out what we can do, because there are ways to manage this and to not lose hope.
Thank you.
Thanks everyone for joining us tonight. We won't have a general meeting next month and in August.
So see you all in September.
In September, yeah. Have a good summer, everyone.
Thank you, Dr. Taylor. Appreciate
you, Dr. Taylor.
Have a good evening. Thank
Sorry
you.
about my slides at the beginning, but I appreciate seeing you all, and I'll talk to you soon.